daughter, age 11, is never hungry in the morning, so she doesn't want breakfast, and I have never forced her to eat. I think by forcing kids to eat at a certain time or finishing their plate, we send the message that they should ignore their hunger cues, which is a bad long-term strategy for eating competency as they grow up. I have been morbidly obese on and off all my life. I'm 61 now and lost 75 kilograms in 14 months with intermittent fasting. It's the only thing that worked for me, and I'm keeping the weight off. The reason lots of doctors don't promote fasting is that they won't make any money. But Dr. Pradip is a true humanitarian. He genuinely cares about people. I love his mindset. Thanks, Doc.
So the fat comes out, comes into your liver, gets converted to some ketones perhaps, and now you're making ketones, and the ketones are being utilized for energy, and then you go for your next meal again. So the body was made to do this. It was not made to just pile on all the time, because that results in increased fat stores, which you'll never break down. So your body was supposed to do this. From the design, you're supposed to do this. So the important thing is that when you eat and you're taking calories, your insulin level obviously goes up. Why? Because insulin has to get that sugar out of the bloodstream. Blood sugar must always come down, because otherwise you get damage from that high glucose level in your bloodstream. That's why we treat diabetes, right? Because the blood sugar, or the glucose rather, attaches itself to proteins, you get glycation end products, and therefore these proteins become dysfunctional. So insulin says, I'm going to take the glucose out, put it down into the storage. First place it puts it into is the liver. When the liver stores are full, then it spills over into the pancreas. More calories come in, there's more glucose, then it goes into the muscles, and it stores everything, and from there into the skin. And that's the way it was supposed to be. But now when we continue to do that, we just keep piling it on. We never get a chance to burn it down, and we're supposed to burn it down. So the biochemistry of the body was made for feeding, fasting cycles. And this is the way the bioengineering of our body was, but we became dysfunctional because as food became more available, we just kept piling it on and on and on and on. And that's the problem that we have today. It's exactly what you said, excessive calories too frequently. So our insulin levels stay high all the time. So that's the biggest problem I found as a cardiologist. You're eating all the time, you're stimulating your insulin all the time, insulin stays high, never gets a chance to come down. And because your insulin doesn't come back down again, you're always in a storage mode. Yeah. This high insulin is the problem. We've hormonally changed because we're eating too frequently. We were not designed to eat that frequently. Insulin's supposed to go up, then come back down again. Up and back down. We stay up all the time, so your body develops, in a simple terms, insulin resistance. Now, the next time you eat, you need even more insulin, because just like wearing a jacket, you first feel it, then you don't feel it. The body, when it has high levels of insulin all the time, it becomes insensitive to it. And that's what's happening. We are a hormonally modified human being now. We're becoming insulin resistant. And this insulin resistance results in higher and higher insulin levels. And that's the problem I found. And I just want to digress a little bit. And I'll tell you how I came to this. In my practice, what was happening is patients were coming in with heart attacks and hardening of the arteries and angina. And I said, okay, there must be a cause. And I looked for it. And the cholesterol, most of the time, was okay. Blood pressure was okay. They were not diabetic. And then I see all this hardening of the arteries. And I'm wondering why. So about 12, 15 years ago, I started doing sugar tests on them, and I found that they actually had mild diabetes, what we call glucose intolerance or impaired fasting glucose. So the sugars were just slightly high, but not enough to make them a diabetic. So I said, okay, fine. So I should put these patients on something to sensitize them and make them better. And I put them on metformin, and I got a lot of resistance from a lot of physicians in the community, plus patients, but the outcomes were better. They actually did better. Then I started doing insulin testing in my office. And I started doing this when I read some information from a physician who wrote a book on insulin, and Dr. Kraft. So it's called the Kraft test. So now what we do is we give them sugar water, patients, and we measure the sugar levels going up and back down again, and said, okay, it went up a little bit. not too bad. But I looked at the insulin response and it was massive in these patients. So I took 100 patients and I saw that they were making so much insulin. And I said, this is ridiculous. Why are you making so much insulin? Well, they had insulin resistance. And then I linked the fact that it's the high insulin level that's actually causing the hardening of the arteries, because the sugar levels are okay. Of course, what happens is over time, it's taking a gallon of insulin to bring your sugar levels under control. Eventually, even that's not enough.
Yeah.
So then the sugar level goes up. And then they go to the doctor and say, oh, your sugar levels are high, or your hemoglobin A1C level is high. Now you're a diabetic. Well, guess what? It's too late. You already have all the hardening of the arteries. You've done so much damage to your arteries. You probably did it for 15 to 20 years. And that's the discovery. And that's what really motivated me to make these changes in my patients, to say that, look, I got to get that insulin level down. And it is that high insulin level that really motivated me to really do the fasting program. Because I said, okay, how am I going to get insulin levels down? How do I do that? I don't have a drug. So that's what, look, the whole thing comes down to insulin. For me, it was. Now, as things happen, I discovered more and more fun things in this fantastic journey. But the bottom line is, it was the high insulin level that really got me into this, because I found that when I brought the insulin levels down, my coronary artery disease, atherosclerosis, just went down. Patients did so much better. And that high insulin level, the only thing I know that really helps to bring that insulin level down, besides metformin and a few other drugs, really is fasting.
Yeah.
Because when you don't eat, guess what? You don't make insulin. That's it. Your insulin levels plummet. And then the next time you eat, you make insulin, but a much less amount, because you're not sensitive. So this fasting, I got into it through this way. Not because I just wanted to make them reduce weight, because I just wanted to reduce blood pressure. It was really the insulin that got me into fasting. Then, of course, I discovered as time went on that, my God, the blood pressures were coming down, and I realized that insulin is a vasoconstrictor. It reduces nitric oxide in your blood vessels, so therefore your blood vessels can't dilate. Now that brings me to hypertension. That I said, oh my God, I was taught, and you were taught, that 95% of hypertension is essential. And this very word essential, there's nothing essential about hypertension. You don't need it. So
should we explain to non-medical listeners what does that term essential mean? When we say essential hypertension, what do we mean by that?
Which means we don't know the cause of it. It's idiopathic. Idiopathic is another word we use, which means we don't really know clearly what the cause is. It's just something that just happens. So this essential hypertension is not really essential. You don't really need it. And I found through my own experiences here that the fasting brought the blood pressures down. And I said, okay, so what's the correlation? It's insulin. I started reading more about insulin. And sure enough, when you give patients an insulin shot, the blood pressure goes up. You take them off insulin, blood pressures come down. Insulin causes nitric oxide depletion in the blood vessels. Nitric oxide, by the way, is a vasodilator. Okay? Nitric oxide is a natural endogenous product that makes your blood vessels dilate. And then when nitric oxide goes down, the vasoconstrict. This is a dynamic state that you're supposed to have. You walk into a cold room, you vasoconstrict. That means your blood vessels go down. When you go into a hot room, you vasodilate. That's a normal response. This nitric oxide is most essential in our body. It is so important for blood vessels that, in fact, there was a Nobel Prize awarded for this nitric oxide, as you know. So for the audience to realize that insulin, when it comes down, your nitric oxide production goes up, and therefore you vasodilate appropriately. Your blood vessels are not imprisoned anymore, and blood pressure started coming down. I said, this is amazing, because for the first time in my life, I felt that the patients were doing something that was actually bringing their blood pressures down. I mean, we always tell patients who have high blood pressure, okay, avoid excess of salt and go do some exercises, and those are fine, because they also can improve nitric oxide production. But this was a very powerful one. When I brought that insulin levels down on these patients through fasting, blood pressures just plummeted, and I had to actually take patients off blood pressure medications. So that's a huge thing that I found with insulin. So fasting seemed to me the best way to really make the patient's blood pressures come down. And I found that the weights came down. And the question is, why did the weight come down? Well, insulin, bottom line for all your listeners, insulin just is a storage molecule.
Yeah.
Puts everything in storage. So when the insulin levels come down, the storage padlocks are taken off. So your fat can now be mobilized.
Yeah.
Now, there's, of course, I can go into all the enzymes that are involved and the hormone-dependent lipase, et cetera, et cetera, et cetera. But the bottom line is when insulin levels come down, now your fat pads are available for metabolism. And I found that the fats just started coming off the patients. And when I would look at these patients who would do the fasting program, I'd look at them and they look great. It's not like their faces are all, the excess of skin hanging off, or they have skin hanging off their arms. No. Fasting patients seemed to lose weight in a more beautiful way. They were actually losing fat, but they were also losing the right amount of skin as well.
Yeah.
Because you see, prior to this, I used to tell patients, okay, you're going to cut your calories to only 850 calories a day. And you're going to have 4 meals a day. Each one is going to be this much. And the patients would come back. Sure, they lost some weight. They would lose a lot, actually, sometimes. But they would look terrible. They would look absolutely terrible. Their faces, their skin, and plus they were miserable because they just they didn't feel good eating small amounts of food frequently. This advice that we gave patients previously, that, hey, cut your calories down by eating 4 small meals a day or nibble throughout the day. Totally wrong in clinical experience. They lost temporary weight. They all would put it back on again. Did it for years. I did it for 15 years and I was sick and tired of it. They would come back miserable saying, Doc, my life's miserable. I only eat this much and I just feel terrible. I'm hungry all the time. And I look at them, they even look miserable. And their skin was just... So when patients were fasting, they would come back and they were laughing. They were so happy. Yeah. The mood was better. And I said, no, why is this guy's mood so good? He hasn't eaten for 2 days now. And he says, Doc, my mood is better than it ever was before. I'm sleeping better as well. And he empowered himself. And I said, no, wait, this is psychological. He's just, he was able to do it, so he's feeling good about himself. He says, no, Doc, I do feel good that I was able to do it. And I'm self-empowered, but also they felt better. And then, of course, as I do the research, I see that there are many substances that are produced during fasting. And one of them is BDNF, which is a big word for brain-derived neurotrophic factor. And what that really basically means is, look, when you are fasting, does nature want you to just crawl into your cave and fall asleep and just die? No, nature wants you to go out there, find your kill or your prey or your find your berries or something. So it actually makes your brain more alert, rejuvenates your brain. And you actually, now there's data to show that you can actually grow new cells as well in prolonged fasting. So what happens is that you actually become more wide-eyed and bushy-tailed. Yeah. And that's what I saw with the patients too. That they were so happy when they walked into my office. You're walking to a cardiologist's office laughing and joking. This is fantastic. So that's something. And then I found that their energy levels, they just not only felt better mentally and the mood was better, but they said that they moved around better. So I said, what does that mean? They said, well, look, my aches and pains went away. I said, come on. I said, yes, I only lost 15 pounds so far, but my joint pains are all gone. No, wait a second. Why is that? Why did the joint pains go away? You don't take off that much weight to take them off your knee. Well, there's inflammation. And I found that inflammation went down in these patients. Yeah, so I said, okay, so how do I measure inflammation? So I looked at the CRP levels on these patients. And I found that the CRP is a blood test. And your audience would know that this is a test that we do to look for inflammation, microinflammation in your blood vessels. And I found that they were coming down. Now, you know how hard it was for me to bring these inflammatory markers down? I mean, we give patients statins, and that does bring down CRP. But I found that these patients who are fasting, the CRP levels came down. And perhaps a lot of the inflammation in the joint, one is the withdrawal And I think that withdrawal it comes in two shapes. There's mental withdrawal, that is, I'm a Pavlovian reflex. I have to eat at 8 o'clock in the morning. I've done that for so many years. The other one is a true biochemical addiction at the level of the brain. So that really concerns me. That's why I do this period to come in, because that gets them rid of the addiction. Because I think addiction is a real issue. They're addicted Pavlovian wise, but they're also biochemically in the brain. And some of them really do go through withdrawal symptoms. And they say, I felt terrible. I started sweating and I had these intense cravings. And I said, God, this sounds like heroin withdrawal. And I think it's real. So that's why I do this, just skipping meals and gradually getting into it. But how long does that take? That's the question. How long does that take? And in my experience, I've been doing this, it takes 3 weeks. At the end of 3 weeks, I can pretty confidently say that the patients have gone through their withdrawals. They're going to be now okay to take on the 18 hours. And that's why I do it that way. And the withdrawals are very real because the foods have addictive properties. Sugar is definitely addictive. We know that. We know dairy products have casomorphine, which actually are addictive. So you crave those things that doc has told you to skip the meals on and all that. But I think that after 3 weeks, they're done. And I tell patients, it's not going to be easy. For the first 3 weeks, you're going to get a lot of cravings. You need social support. You need to structure your life. You need to do your shopping during the times that you're going to be eating that meal. Otherwise, so you keep your mind busy and you got to get your 7 hours of sleep. And so the withdrawal issue is very important. That's why I do this gradual stuff. And then the answer to the second part, the women, definitely, women are not exempt from CAD and heart disease. And something that applies to you and me is Asian women too. Did you know that the incidence of coronary artery disease in Indian women is actually higher than Indian men? But it's just that they don't get diagnosed. And they don't seem to complain that much. So they don't come to the doctor's office. But actually, I've seen worse coronary artery disease in Indian women in my office than in Indian men. And in Indians in general, they have far more coronary artery disease than Caucasians. So it's a huge problem. So I think that women are certainly a population that is not exempt from coronary artery disease. Now, the fasting programs in women, there are some data to suggest that they may not benefit as much as men, but overall, I think that what I've seen is that they also seem to benefit just as much. So I don't make much distinction between men and women. They come in here, I work them up the same way. I'm very aggressive with the women as well. Especially women from South Asia. When they walk in, they've got my antennas up. In fact, any South Asian that walks into my office, my antennas are up because they're what I call tofis. They're thin on the outside, they're fat on the inside, and they're metabolically very deranged. And there are specific things that I tell them about fasting and dietary recommendations for their diet. And the reasons have to do with vitamin K2 as well, which I'm finding absolutely fascinating these days. So
no, I very much appreciate that perspective. Thank you, first of all, for sharing that. You're seeing lots of coronary artery disease, potentially worse in South Asian women than South Asian men. I don't think that is commonly known. I did not know that. And actually, I'm now thinking of people and women in my family. I'm thinking, right, okay, maybe instead of thinking about the men, we need to start thinking about the women as well in terms of, prevention, in terms of getting early screening done, blood tests, maybe, coronary calcium score, or, whatever might be available to people. My experience of fasting, in inverted commas, because fasting can mean so many different things to so many different people, is, I have seen some women with hormonal problems. I'm not talking about necessarily insulin hormonal problems. I'm talking more about kind of around the menopause, let's say, or estrogen, progesterone, sort of imbalance issues. I found with some women, it can be a bit challenging for fasting, and some women don't do so well. But I've also found many women who thrive on it. So I think a lot of the time I've noticed this on social media a lot, people try to, it doesn't work for women. It's like, well, what do you mean 100% of women all the time? It's like, and this is why I love talking to real life clinicians. It's like, well, we see that not everything works for everyone all of the time, and we have to tweak our view depending on what we see. And when we make these kind of gross generalizations that fasting doesn't work for women, it's like, well, we put, like, let's say there's that subsection of women who thrive on fasting. Well, they get put off. They think, oh, it's not for me. And it's kind of like, well, there's no one size fits all in anything. And as you see enough patients, you kind of realize that there's very few, although fasting might be one of them, I guess you might argue. But do you know what I mean? I kind of feel these days we get too polarized on these things, and we just miss the kind of nuance that's actually there.
No, you're absolutely right. And this is the new medicine. We're going to become more individual. Okay, why is this lady not able to enter into my fasting program? She really needs to. Her BMI is 42, and she has all this stuff going on. There may be other reasons. She may have so much stress in her life. She may have financial problems that she can't buy the right kinds of foods that I want her to buy. She may be in a very dysfunctional relationships, and that may be causing so many problems for her. She may not be sleeping at night. A simple thing. She may have undiagnosed obstructive sleep apnea, which is why during the daytime she has so much fatigue, tiredness, and she's never going to develop enough willpower to enter into my program until I get her a good night's sleep. So maybe put a CPAP on her for the time being, and then see that, oh yeah, now she can abide by the principles of the fasting. So, it just means looking deeper into why weren't you able to do this? There are obvious factors why you cannot. Where's your willpower? Why don't you have the willpower? Let's look into this. And we don't always find the answers to everything, but I think that looking at them overall, so the sleep apnea is a huge issue, by the way. Massive problem that I find. So oftentimes, temporarily, I do put them on a CPAP mask and say that you're going to have more energy, mental energy and clarity and less neurodysfunctional during the daytime. And therefore, you will be able to abide by the diet. But the goal is really to lose the weight so that we can get you off the CPAP eventually. Yeah.
So back to the kind of therapeutic use of fasting. So you do this kind of 3-week program where they unprocess their diet. Then you put them on this kind of 18-hour fast. So they're having 2 meals a day over 6 hours. And then for 18 hours, they're not consuming anything. Sorry to interrupt. If you are enjoying this content, there's loads more just like it on my channel. So please do take a moment to press subscribe, hit the notification bell. And now back to the conversation. We must talk about any contraindications like insulin or blood sugar medications at some point, just to make sure that, people who are listening, who want to try stuff, that we've covered that. But also, I want to go a bit further because I know you have used 24-hour fasting with patients. I know you have used 3-day fasts, and you have also shared in previous conversations some very powerful statistics. One in particular, I remember on a 7-day fast, you shared a statistic, a bit of research from Boston in terms of what that does to your lifetime cancer risk. So maybe you could talk about some of these longer fasts, and then practically, how do people start going about that?
Yes. So absolutely. So at all times, they are supposed to take their blood pressures twice a day. Make sure that the blood pressure not going down because I do not stop the blood pressure medications right off the bat. So the blood pressure medication reduction will be done depending on your blood pressure readings. As far as blood sugar is concerned, if they are on oral agents, I'll continue those oral agents while they're doing the 18-hour fast periods. Even the 24-hour fast, I'll keep them on it, and I will ask them to monitor the blood sugars. Now, continuous glucose monitoring, the little devices, I only advise those on patients who are on insulin when I'm fasting them, because I want to make sure that their insulins don't drop off. But when a patient is taking insulin and he does the 24-hour fasts, I drop the insulin levels by half first, insulin dosage by half, and I monitor the blood sugars. And then when they go beyond 24-hour fasts, I stop insulin completely. I stop it completely because I don't want them to become hypoglycemic. So oral agents, I will continue. Insulin, I will discontinue if I'm doing more than 24 hours, but I monitor the blood sugars very closely. And then that brings me to a little longer fast. Before I go to longer fast, I make them do a 36-hour fast. So I'll make them do that once a week. Once a week means that evening rolls around, skip that meal also, and then have yourself a breakfast. treat yourself with a breakfast the next day. And that brings it to 36 hours. So I make them do at least one 36-hour fast for maybe, 2 consecutive weeks. And then I'll take them to higher levels.
Can I just clarify that? So the 36-hour fast, the way you have found it most beneficial for most of your patients is what you skip one evening meal to the next evening meal. When does that fasting time? I know you can do it any way you want, but what have you found to work? Can we just clarify that?
Yeah. So the patients already are used to having only one meal a day.
Okay.
So then I'll say skip that one meal and then have the next meal when you're supposed to have them. That'll bring it to 36 hours. So for most patients these days, they're having their evening meals because it's more social. They're having it with their families.
Okay.
So they'll skip breakfast, they'll skip lunch. Evening comes around, they're supposed to eat. And I tell them, skip it and go and have breakfast the next day. That brings them to 36 hours.
I guess if they're already used to having one meal a day, then actually skipping that evening meal is kind of, I don't know, just go to bed early as well, sort of, it's, I like that. So what stage do you take them from this 2 meal a day, which is this, this 6-hour eating window? You do that initially for the 18-hour fast, then you take them to 24 hours, do you, with just 1 meal a day? Is that how you do it?
That's exactly how I do it. And then they're doing 1 meal a day, 5 days a week. Weekends, they're going to have 2 meals. They do that for 2 weeks. And then I say, okay, you've been doing this for 2 weeks now. You've been having only 1 meal a day. Next few weeks, 1 day a week, you're going to go to 36. And the way you're going to do it is you're going to skip that 1 meal also and then have a breakfast the next day. So that'll bring you to and I want to see how you feel. And most of them come back saying, I just missed the meal in the evening. I watched a movie and went to bed. So why am I going from 24 to 36? Because I want to get them ready for longer fasts, especially if they're tremendously overweight and they're metabolically deranged. What's the biochemical advantage between 24 and 36? By 36 hours, almost all of them will be in some degree of ketogenesis. So it's hard to know who's going to start spilling ketones at 18 hours, 24 hours, 30 or 32 hours. It's hard to know that. So when I prime them, then I'm finding that there's longer and longer periods of ketogenesis. That means they go into ketone production at 16 hours. So long as they made their dietary changes, gradually got into this, the ketogenesis phase starts a little bit sooner at about 16 hours. And the most motivated patients say that, I want to know. I said, okay, if you want to know, then go to the pharmacy and pick up some keto sticks. And just test your urine and tell me when you started spilling the ketones. So after 24-hour fast, almost all of them are spilling ketones. And when they're spilling ketones, I know what's going on with their physiology at that point. I know that they're getting the benefits of some degree of autophagy, growth hormone, BDNF production, and mitophagy. I know that's happening because they're spilling ketones. So spilling ketones. So that's another motivating thing. In the patient who's showing me the interest and the ones I really want them to, yes, give them the tool. Take this home. Check your ketones. That's what I find so fascinating. So by 36 hours, they're making the ketones. So they'll do that for a couple of weeks where they now went to 36-hour fasts once a week for 2 weeks. Now, at that point, depending on how motivated they feel and how well they are doing, now I'll go to more prolonged fasts. And my favorite fast is the 3-day water fast. And most of them, I'm telling you, greater than 95% of them, when they've graduated to this point, where they've gradually gone and done all this, they're able to do the 3-day water fast with no difficulty whatsoever. And if they get cramps, then I tell them, okay, take a glass of water and put a pinch of salt in it and just down it and you'll feel better. But most of them don't because they've adapted themselves. If you go into a 3-day water fast too quickly, you're going to get more cramps, but more importantly, you're going to go through what is known as keto flu and you just feel terrible and achy and you just feel really bad. So I do it gradually. But I must make them go to a 3-day water fast. I use it in that case. I also use it in patients who are able to lose weight, but then they reach a plateau. So now they're weighing 230 pounds, and I want them to have more weight loss. So they've been doing this now for a month, and they said, look, doc, I just can't shed any more weight now. I've done everything you're saying, and I'll put them on a 3-day water fast. And lo and behold, they'll start losing weight again. So I use that in patients who've reached a plateau, going to the 3-day water fast.
Thank you for sharing that. I think something I did want to bring up today, because I know a lot of people, and again, we're all influenced by the online world or the patients that we've seen or the online world that we inhabit. And, I spoke to David Sinclair, this Harvard professor who talks about aging in a very, very profound and novel way. And, when I put out that episode with David, a lot of people were saying, look, asking people to skip meals is very triggering for people with eating disorders. And I know eating disorders are on the rise massively all over the world, certainly here in the UK and in America. So I think we need to be careful about that. I think it's worth me just flagging that here, that potentially this advice is not for people with eating disorders. That's a sort of separate issue. Well, I'd welcome your perspective on that. But also, is it possible that we take these things to extremes? I guess there would be some people. We mentioned Anna Lemke's book before, Dopamine Nation, and that we're living in a world of addicts now, and that she mentions that the smartphone is the modern day hypodermic needle, which I thought was a very provocative way, but I actually completely agree with her of talking about it. There's health, there's physical, biochemical health, but there's also this kind of emotional health and our mental well-being. Do you think, as much as you love fasting, do you think some people, they can sort of overdo it and get so addicted to kind of that feeling of fasting and actually go to an extreme which potentially could become problematic?
I think you're right. It can happen. Fortunately, I haven't seen it here with somebody. I tell them, stop now, stop. This is enough. Now you should be eating 2 meals a day. And, I think that the pattern you need to settle down in is, for you, I think that 2 meals a day in a 6 or 8 hour window period may be a nice thing for you to do chronically to maintain what you've gained, the benefits that you've already gained. Then I haven't seen any patients who ignored that and continued to do the 3-day water fasts on a weekly basis or whatever, or 2 weekly basis. I haven't seen that. But you are absolutely right that there are some patients who clearly have an eating disorder, and they clearly have a type of addiction, and they're going up at night and they creep downstairs and they're eating away 5 bars of chocolates and all this kinds of stuff. And those patients clearly do need help. And I will not deal with those on my own. I will supervise it, but I'll send them to a psychologist that actually specializes in addictions, because they have to really spend time with that patient about addiction behavior. And it's not just behavior about the food. There may be other issues that are actually triggering, because you see, you slide from one addiction to the other, to the other. So you can't take off this alone on its own until you also take care of the sugar and maybe the cell phone and other digital gadgets that give you the instant gratifications. And there may even be other issues. He may be a gambler or have other type of deviant behavior addictions. So no, you're absolutely right. So recognizing those with the biggest problems, and addiction is a huge problem. And it's becoming more known now that the addiction is to not only sugar, but it's also addicted to processed food content. Processed foods and the content of processed foods are very addictive. I think that's why you want to change the type of food that so you're getting rid of all the addictive substances in the food, the addictive sugar in the food, and then addictive behaviors in other aspects of your life as well. So it's really looking at the whole thing. It's a huge problem. It's a huge problem. And yes, we are an addicted nation. And that's why it's making it so easier for us to become addicted to food later on in life, because it starts at a very young age. You're already getting addicted to gadgets and instant gratification.
I want to move on to the mental benefits shortly of fasting, because I think there's a real important piece there that we touched on a couple of times in the conversation already. Before I do, I sort of feel that there's so much divisiveness and, frankly, fighting about different diets that I think sometimes gets so unhelpful for the general public. They see doctors who they admire saying this diet has got this evidence, this is really good, and they see another doctor who they admire say this diet's really good and it has all this evidence. And I think, and I know this from talking to patients and talking to the public, that many people find this incredibly confusing. I really like fasting for the right person in the right state of health. I kind of see it as the great unifier in many ways, because as long as you are metabolically able to do that fast, you know, whether you choose to eat meat and fish or whether you choose to be vegan, if you are whole food primarily and not having much processed food at all in your diet, then you're still going to get benefits from fasting, right? Whether you're low carb or whether you're vegan. And, you know, it's interesting, that video that you did on fasting for survival on YouTube, which is, you know, had millions of views. I was reading through the comments just before this conversation, Dr. Jamnadas, and the top comment was really, I think, encompasses everything that you stand for. He, I think, said he was mostly plant-based, and he started off following your advice with a whole food, mostly plant-based diet. I think he started off with 18-hour fasts. He moved up to 24-hour ones. I can't quite remember. Then he moved to maybe 1 3-day one every 6 months. And he's documented his health journey over 2 years. And it is utterly remarkable that you put out a video on YouTube and you have completely empowered that guy to transform his life. So first of all, I want to acknowledge you for that. That's just one of millions of people who've seen that video and changed their lives. And that's just incredible work that you're doing. But what do you think about this concept that fasting could be the great unifier? No matter what tribe you belong to, you can still get involved with fasting and yield and reap many of those benefits.
You're absolutely right. The various dietary programs that have come out have confused the public. It's confused the physicians as well.
Yeah.
I mean, my patients come in and say that I'm following this diet, that diet, and nothing happened, and this one's too hard for me, and this one's too restrictive for me, and it doesn't fit with my lifestyle. I understand that. Fasting forgives you. Fasting, in a sense, forgives you for certain foods that you may then consume. And actually, think about it this way also. You eat that slice of bread after a fast, your insulin response is totally different in the fasting state than in a fed state. Mm-hmm. You're going to make less insulin for the same slice of bread in a fasting state. So it's, and the type of food that they consume. So when I first started out, I was years and years and years ago, I would say, oh, you got to be a vegetarian. You got to drop all meats. And being here in the United States, how many patients are going to become vegetarian, right? So, and then as the data came out and I started studying more and more, I changed. Yeah. I decided that, hey, there's something wrong with this. You know, people should be able to eat ancestral foods and what they grew up with. But the problem was processed foods. Then we take the foods and we process them, we change them, and all the additives that we put into it, and the way we grow our food or way we get our meats has changed. So I said, no, this is not right. When I studied non-vegetarian diets around the world, how come there is low incidence of heart disease? There are populations that eat only meat and only drink milk and blood, or the populations that only eat starches and a lot of it, and they also live long. Yeah, what's the commonality? Yeah. What was the commonality in all of them? The commonality was no processed foods, no additives, right? No sugar. So they all had simple diets. So then I came up with my own plan and I said, listen, what do you like to eat? What do you like to eat? So you want to eat red meat? Okay, then eat grass-finished meat because that'll have more nutrients in it. The fats will be the right kind of fats. You will not have all those omega-6s in there. You'll have more natural fats in there. Yeah. And if you want to eat eggs, chicken, fish. So I let them do that. And I said, but you got to also introduce plants in your diet because you need the plants, not for you. Yeah, and you're going to get some water-soluble vitamins, et cetera, into your system when you eat plants and all. But it's really for your gut bacteria. So again, I had to read a lot about the microbiome to understand that the fiber is hugely important. Very important.
Yeah.
And so I tell them, eat your vegetables as well. So this is my diet plan.
Yeah.
It's not so restricted. Just stay away from anything that your great-great-grandfather wouldn't eat, and no processed foods. Anything in a packet, box, barcode. Stay away from anything made into a flour. And that's been a hard one, the flour one.
Yeah.
Also in South
It's everywhere.
Asia, it's a huge problem.
I love this. I'm so enjoying speaking to you. There's a real kind of, there's just a beautiful energy. There's also this kind of real life practicalness that you know what it's like when these patients come in and you've got in your head the ideal thing, but you got to work with people and their tastes and their preferences and their culture and what they want. And I really do strongly feel that too many people these days on social media commentate, they look at the science and go, oh, this is what everyone needs to do. It's like, it's just not how it works in real life. In my experience, people are different. They've got different desires. They've got different cultures, different preferences. So I really like that. You've mentioned all the kind of physical benefits, the biochemical benefits when we have a period of not taking in food, a period of fasting. But there's also something really powerful, isn't there? Like you have touched on several times, but what it does for you when you know, oh, I can go 12 hours without food. I can go 18 hours. Wow, actually, I can go 24 hours and I don't actually need to put something in my mouth. I think we shouldn't undervalue just what that does for someone. I think it's freedom. It's freedom from a dependency on food. Addictive foods, processed food, sugar. It means that you can go about, you're out on the train station or the airport and there's no good food to have. Cool, just don't eat. Take the flight, don't eat. There's a real freedom, which many people feel that they're in chains, I guess, to the food industry and to their hunger and their stomach. So, can you speak a little bit about that and why you feel that's so important?
Yeah, I love the fact that you use that word freedom. Because, I said, okay, it empowers the patient, but it is a real freedom. It's a freedom that they know that what their behavior resulted in no adverse effect and that they were able to overcome this, which they never thought they could overcome. So these little hurdles that they're overcoming in their diet actually has huge repercussions in other aspects of their life. And really, honestly, it percolates into their workplace, into their family life, in their social interactions with their friends, and I've seen that these people they just become more self-confident, and I think it's because we introduce terms to them like that's who you are, the real you. So it opens up a new aspect of their existence, that there is a part of me that's separate and apart from my body and from my mind and my cravings and my stomach and my feelings and all these things. And that's the real me. And of course, this gets into some of that part that I have a huge interest in, which is, who are you?
Yeah.
What, who are you really? Where is the you? And why can't you, that you, change your behavior? Of course you can, because you need to change your identification. So this is an identification change that I see the patients doing. Yeah. They realize that they are in charge, that them inside them, not the body, not the mind. There's actually an awareness, an amness, an I am. And that is huge. And I found that people who have done this program over the last few years, they actually get work promotions. They actually become better supervisors. They become just better family members and caregivers. And it's miraculous how one thing, because it's showing them that, yes, you are in charge. Look, you can do it. You can do it. And they just self-empower themselves. They feel so good. Self-confidence just goes off the roof. And I think that there's a, I'm learning more about this. But I think it does boil down to, because that also brings me to stress management. Because one of the things we do tell our patients is that if you start getting stressed out during all these periods where you're getting into the fasting period, you need to go out and do some meditation. we tell them, and we show them how to meditate. And I have a very simple meditation technique where I just basically ask the patients to, okay, just close your eyes and just concentrate on your breathing only. And when a thought comes, let the thought go. Don't follow up on it, because then another thought will come in a few minutes. Don't follow up on it. Wait. Just come back to your breathing. Concentrate on your breathing as the breath goes in and out. And you will find that there'll be gaps in between your thoughts that get longer and longer and longer. And my patients have all said, yes, you're absolutely right. There's blankness. I said, well, that blankness when you don't have a thought or when you're not thinking of something, that's you. That's the real you. And when you come out of this for 15, 20 minutes, you will realize that there is that you in you, and you can make up your mind about anything. You can do anything. It'll empower you, and you'll feel less stressed out. You'll feel less compelled. You're less automatic. You will be, you will become, as you said, that word that you used, you'll have freedom. You'll have freedom. And I find that fascinating. So you see, this whole thing, I said this in the beginning, that, fasting seems to open up that onion into all different parts of your life.